This video is part 2 in our 5-part series on why mid-back pain between the shoulder blades usually isn't a rhomboid problem. In the video, I cover the following: why does an entrapment of the dorsal scapular nerve happen, clinical presentations and signs of an entrapment, and treatment protocols and processes to ensure long-lasting pain relief from removing the entrapment. For those of you who don't know me, my name is Dr. Matt Maggio, and I am a non-surgical expert in chronic pain treatment, specifically for conditions affecting the neck, upper back, shoulder, and arm. My focus is on finding and fixing nerves that become stuck to muscles with a glue-like substance called adhesion, also known as scar tissue, and then reducing inflammation from chronic pain naturally without the use of medications or injections. This leads to a big increase in flexibility, functioning, and long-lasting pain relief. I'm also the creator of the PEAK method, where we teach manual therapists a new injury treatment system that eliminates the frustrations of not getting consistent results and produces long-lasting pain relief for their clients, all while working 50% less. All right, this is video 2 in a 5-part series. If you haven't watched the first video or any of the other videos in the series, if you're watching on YouTube, I'll link it up top. Anywhere else, it'll be down in the description box below. But pain here in the rhomboid area usually isn't a rhomboid problem. This time I'm going to be talking about an entrapment of the dorsal scapular nerve. So let's get right into it. So dorsal scapular nerve, what is it? What does it do? It is a pretty important nerve, and it actually helps to work with two very big and important muscles in the posterior part of the neck. It helps to innervate and move the levator scap, as well as the rhomboid group as well. It does a lot of important functions when it comes to a lot of those motions in the back part of the neck, as well as shoulder stability, neck stability, all that good stuff. So why does it get entrapped? I talk about this all the time. So nerves are built with about 15% of extra slack over time. They eventually get stuck to the muscles with a glue-like substance called adhesion, also known as scar tissue. And as that adhesion gets bigger and bigger, eventually it gets stuck to the nerve, creates a nerve entrapment. And nerves do not like to be entrapped. And a lot of people are like, well, how did I get scar tissue or adhesion? I didn't have an injury. It's actually more common from repetitive overuse, sitting too much, staring down at our devices, basically just being a normal human in society. Going to develop a lot of that adhesion, and then eventually it does get stuck to the nerve. And when it gets stuck to the nerve, kind of changes the whole ball game. You're going to have postural distortions, biomechanical problems, all sorts of things, because the body does not want the nerves to get stuck. If the nerves don't work, you don't work. So it'll sacrifice a lot of things once that nerve actually gets entrapped. Symptoms of an entrapment, usually early on, I'll see some numbness, some aching, some burning, some tension in there as well. I will start to see those postural distortions a little bit later on. Maybe that shoulder's rolled forward, maybe that neck is elevated to take some slack off of there and give that nerve a little bit of space to operate, which in turn causes a whole different cascade of problems as well as we go. So why is fixing the nerve first so important? Over the years, I always thought it was let's just treat the muscle first, the fascia, the ligaments and things like that, and then eventually we'll get to the nerve. But what I started to realize is that the nerve is like the hierarchy, and we have to fix the nerve entrapment first, because if we don't fix anything else, all those problems are going to continue to come back. So we got to get rid of the nerve entrapment first, then start to treat the surrounding tissues. I think the neuromuscular people have it backwards. They do think it is a problem with the nervous system and how it's functioning, but they say things like, oh, things aren't firing correctly or they're inhibited. They think it's more of a brain and wiring problem, where I'm really seeing that it's actually something's getting stuck out in the periphery. One of the main guys, Vladimir Janda, who's the godfather of the neuromuscular movement, even said in his research, you have to fix the peripheral dysfunction first before you ever reprogram the brain. So that's why a lot of those neuromuscular treatments, they get temporary results, but they don't have anything long lasting, because they're not addressing where the real problem is, which is where the nerve is getting stuck somewhere along the track. It's not a brain problem. Another thing that a lot of people miss, especially when treating nerve entrapments, they'll go into the area here in the rhomboids where the client is going to feel that. So essentially, a lot of times what is happening is it's getting stuck. It's getting stuck higher up, and the dorsal scapular nerve actually has a component of the C5 spinal root. And if you actually look in where these nerves come out in between here and what's called the scalenes, is basically whatever whatever is the lower nerve level is usually the one where it's coming out. So this gets caught between the C4 and C5. So a lot of times these problems that are down here started up here. So it's like someone's holding and pinching here and then they're pulling down here. So most providers just kind of go into where it hurts. I say this is the effect, but it's not the cause. So a lot of times people, you'll have a client come in and they'll draw X's and pain all over this area, and you'll go in there and beat on it until, the cows come home and they feel a little bit better, but then it comes back. A lot of times it's because we're not addressing this higher up component in here. So in the video last time in the series, I demonstrated like an accessory nerve entrapment treatment. It was a little bit higher up, like kind of more in like this like T1, T2 area as we treat it. But the treatment for the dorsal scapular nerve is going to be very similar to the accessory nerve. So go back and watch that. We're just going to be a little bit lower, basically from, I'd say from like T3 to like T4, T5 is where you're going to catch that a little bit as you go in there and kind of clean that up. And then there's mechanics of that as well. But what's really missing, and a lot of people, I did it for years too, is I didn't address like the actual root of the problem, literally in the spinal root. So what I want to link up this week is actually a demonstration video and palpation video of me treating the nerve roots specifically at this area, because it's so important. Because if you just continue to treat here and you don't fix up here, it's going to keep coming back and you're going to be frustrated. The client's going to be frustrated and you're just going to keep banging away down here and not getting any really long lasting results. So I'm going to link that video up right now. We're going to be treating the nerve roots at scalenes. I wanted to show here with the model, just so you can get a better idea of how the setup is. The key here is we're only going to be going a very short distance, but when these nerve roots are really caught up and create a lot of problems with overall functioning of the neck, can cause some pain down the shoulder, back through here as well. So symptom location is really key. And when you're seeing a limited test, when they're doing that upper cervical functional test, what's going to happen is it's going to refer some pain there. So if you can clean these up, it's going to make a big difference. So coming a little closer here. So the way that I'm going to set up is you're going to have the client right here, and the top of their shoulder blades will be right off the edge of the table. And then you're basically going to have your hands cradled just like this. And this, say we're treating the left side, so the top hand is going to be our support hand. So what I like to do is I count some landmarks from where we go, and then down. So we go down here, and the first one you're going to find is at C7. So I want you to go 7, 6, 5, 4. And that's where you're going to hold and cradle. And it's going to go just like this. And then you're going to bring the other hand around just like that. And then everything is going to be nice and supported. And you're going to be able to fulcrum and open that up. Because what we're treating in here is these nerve roots, and the scalenes go over top. So this will really help you with the palpation. So we're going to create a fulcrum. You see how my hands are here, and what you're going to do is open it up just like that. You have a little bit of tension, and we're going to go in and feel on each one of these nerve roots, and we're going to find the area that's the least compressible, because that's where that scar tissue is. So what you're going to do is sink in and see what you feel. So first you'll have the C5, C6, then you'll have C6, C7, and then C7, C8. Those are the three that you're going to work in there. So when you find the one that compresses the least, that's where you're going to want to treat. So the way the treatment is going to work, you're going to be in just like this, and what you're going to do is start them in neutral, and say we're going to treat the C6, C7. So we're right here, my thumb is here, and we're going to use the pads of our thumb to open it up this way. That's going to allow us to get in there. We're going to be nice and relaxed, and then the first thing we're going to do is we're going to get some depth with a pec push into there, and then we're going to come out just a little bit. Normally we come out 10 to 20% when we're treating just scar tissue, but since this nerve is here and it's deep, we're only going to come out 5%. Now the next thing you're going to do is you're going to get your tension with a body lean like that, and you're going to get right over top of that, and you want to pause just before that happens and hold that. And the way the motion is going to work is you're going to take this left foot, and this is going to be your push foot, and your right foot is going to pull. So what you'll feel is a slight push and a slight pull as I bring it through just like that. And we're not going very far as we go through, because we're only treating that one level as we go in there. And only treating that one level as we go in there. So this is actually going to be what's called that internal slide. So when you set it up just like this, you're here, your depth comes with your pec push, your tension comes with your body, and you're going to push with that left foot and pull with that right, and you're going to force that
to roll over your thumb, but you're not going to move your thumb and it's going to come from there. So I'm going to show what it looks like on an actual client. So once again, positioning, you're going to have them come to the edge of the table, just like that. One more scoot back. So their shoulders are here and their head's going to be cradled in here. First step you always want to do is have them tuck their hands under their butt. It's going to help everything relax. So say we're treating that left side like we said. This right hand is going to be there. We're going to go in and count. We're going to have C7, C6, C5, C4. I'm going to create that knife edge and just hold there and see how it's nice and supported there. From there, and now the next one we're going to go in and we're going to start to palpate those different regions. So we want to use this thumb as a fulcrum to open it up as we're palpating. And we're going to sink in first, and that's 5, 6. Push with that pec and see, is that compressing or not? Then work our way down. That's 6, 7. And then we're going to go 7, 8. In whichever area feels like it's not compressing enough, that's where that scar tissue is. So let's say this one's at C6, C7. I'm going to start here nice and neutral. My arms are nice and relaxed on my side. And what I'm going to do is take this right hand and push it into my left. That allows my thumb to sink in there nice and easy. Then what's going to happen is I'm going to get some depth by pushing with my pec, and my tension is going to be that body lean. I'm going to be nice and loaded, and as we said, I'm going to push with this left leg and pull with the right, and we're going to go nice and easy, and I'm going to keep that pressure and that tension and let that slide over my finger. I'm not sliding my finger, I'm letting it come to me because that is internal slide, not external slide. So the key is palpate it under tension. Once it's there, you're going to fulcrum that in, nice and relaxed, and you're going to get that pec push for your depth and a body lead for the tension. And then you're going to push with this left and pull with that right and have it go through just like that. Good.
So just a couple take homes from the video. It's very slow, very deliberate, very precise. I'm never in a rush. I'm trying to get the exact treatment that it needs. You know, a lot of times, a lot of providers, especially manual therapists, want to do all the treatment instead of like what it actually needs. But problems continue to happen when people try to address these nerve entrapments. Usually what happens is they're too compressive and they get too much depth. And then it just gets stuck. It pulls, it hurts like hell. It temporarily feels better, but doesn't fix anything. And then those vectors are off too. So really slow down with your mechanics and how you do it, and don't be in a rush. Next is then sometimes the client active range of motion is off, not as much for the scalenes because you're doing most of it, but when you're treating like into that entrapment of the dorsal scapular down through the rhomboids, a lot of times the client moves too fast. You didn't shorten it enough. You didn't palpate it enough. You didn't really find where it is, and then you're missing that window. And the way to break down these entrapments is you need proper depth, then tension, then them to go through a full range of motion and feel that tissue slide. And usually one of those components is missing, so people get frustrated and just throw some cups on it or dig in there with their elbow, and all you're getting is a bunch of depth. You're not getting any tension, so you're not fixing anything long term. Next is just not letting that tissue slide. The tissue has to slide. I say the nerves are like Goldilocks. They want just the right amount of tension, just the right amount of depth. And if it's off, you didn't set it up right. Then go back and reset it up. Be slow. In order to go fast, you got to go slow. Next is just treating too aggressively. Don't jam your elbow in there. You're just pissing the nerve off. You're not doing anything to actually fix it. Might hurt like hell for the client. They're like, oh yeah, they got that deep tissue got in there. This isn't deep tissue. The nerve isn't that deep. It's in there. You can find it. You can fix it. Be gentle to the nerves. Don't beat the hell out of them. They don't like that. And that's why they're not getting better long-term. And every time the client comes back in, you're right back to where you started. And you're like, what's going on? Because you treated too aggressively. Next is only treating at the sign of the symptom, not checking the nerve roots. As I said before, a lot of people just go right where it hurts, but we need to know everything and understand the anatomy and where everything is going. We need to clean up top first and then clean down low, because if we go backwards, that's why it's never getting any better. That problem continues to come back. That's all I got in the video. I appreciate you watching. If you got any insights, share them in the comment section below. I try my best to engage with everybody out there and, share some information and some ideas. Another thing you could do is you could share this with other providers that, it might help, do me a solid, get the word out there. I want people doing good work so we can help more people get out of pain, get the treatment that they need. And lastly, if you like what I'm sharing, what I'm doing, you can go download our free training modules where we really go into the ins and outs of understanding chronic neck pain, how to address it, how to be more efficient, and going from just like trying to provide a service, but instead providing a true solution. All the links to do that are wherever you're consuming this video. I appreciate you watching, and I'll catch you on the next one. Bye.